Alright. I do not really feel like doing this, but it's okay. Study a little bit is good. Alright. Let's see if I have everything down. So how is atrial fibrillation treated? The treatment of atrial fibrillation consists of three major considerations. Control of ventricular rate, okay, conversion, if possible or feasible, to sinus rhythm. Sinus rhythm is whenever the heart contracts starting at the sinus node, and that's the presence of the P waves and the ECG. Prevention of thromboembolic events, particularly CVA. So thromboembolic. I think it's talking about blood clotting. Prevention, atrial fibrillation, particularly CVA. Okay. So rate control is best managed with beta-adrenergic blocker or calcium channel blockers. How do you pronounce that? Diltiazem pronunciation.
Diltiazem. Brand, Cardizem. Translation, Diltiazem.
Diltiazem. Okay, diltiazem. So diltiazem and verapamil are calcium channel blockers. So rate control can be managed with beta-adrenergic blockers or calcium channel blockers, or less desirable, digoxin. Digoxin should be used in patients with poor left ventricle. I have to make sure that stands for LV. Oops. Okay. Yep. Left ventricle systolic function. Okay. And those with contraindication to beta blockers. Contraindication is to withhold a medical treatment due to harm. And those with contraindication to beta blockers and calcium channel blockers. Okay. It provides good heart rate control at rest, but often suboptimal rate during exertion. Okay. For conversion to sinus rhythm, in the stable patient with duration of symptoms less than 48 hours, it's best managed initially with antiarrhythmic agents. Amiodarone, ibutylide, propafenone, or prosinamide. Excuse me. So now I'm thinking, how do I best remember these medications? I think I just have to go find some pharmacology book to introduce myself to pharmacological information. Okay. So antiarrhythmic agents, amiodarone, ibutylide, propafenone, prosinamide. In the unstable patient or patient with acute ischemia, hypotension, or pulmonary edema, also called wet lungs. Ischemia is insufficient flow, right? Insufficient ischemia. It's insufficient blood flow. General, yeah. Okay. Insufficient blood flow. Pulmonary edema, which is wet lungs, excess fluid. Oh, yeah, I already said that. Immediate synchronized electrical cardioversion. starting at 200 joules should be performed without interruption of antiarrhythmic therapy. So electrical cardioversion performed first without antiarrhythmic therapy. I think that's what it means initially. Patients with atrial fibrillation of 1 year duration or longer, or those with left atrial size of more than 5 centimeters on echocardiography cardioversion are not recommended this therapy because of its low success rate. Echocardiography cardioversion. I did not type that well. Okay, cardioversion is used. Yeah. Before it, you'll need a echocardiogram. Oh. I see. So cardioversion. So what is cardioversion in general just not effective? So you need antiarrhythmic agents, beta adrenergic blockers, calcium channel blockers, digoxin. You need medication for better treatment, I guess. Patients with recent atrial fibrillation of more than 2 days duration should be started on warfarin and anticoagulated to an INR. So that's an international normalized ratio. It's a calculation based on results of PT and is used to monitor individuals who are being treated with blood thinning medication. They're used to monitor the effectiveness of anticoagulant warfarin. So they're used to monitor the effectiveness of anticoagulant warfarin. Risk for embolic CVA. Where am I? Oh, patients today should be starting an anticoagulated to an INR between. It's a calculation between 2 and 3 for at least 3 weeks. So that's a certain amount of warfarin, I'm guessing. But it's a certain amount based on results of a. I think I just need to know that it's used to monitor the effectiveness of warfarin before any attempt to cardiovert to sinus rhythm because of the significant risk for embolic CVA, for risk of a stroke. So you want to monitor anticoagulation from the use of warfarin before attempting to shock the body because of the risk of a stroke. Earlier cardioversion attempts could be considered if the patient is at adequate anticoagulation levels and no evidence of intra-chamber thrombus, so nothing's blocking the chambers of the cardiac system. By transesophageal echocardiography. Okay. Those patients with chronic atrial fibrillation should be on lifelong warfarin unless an absolute contraindication to warfarin exists, or the patient cannot reliably take warfarin. What percentage of patients with atrial fibrillation converted to sinus rhythm will revert into atrial fibrillation? 50% will revert to atrial fibrillation within 1 year of cardioversion, regardless of medical therapy. Wonder why that is. What is the risk of CVA in patients with atrial fibrillation with or without anticoagulation? Patients with atrial fibrillation not anticoagulated with warfarin have a 25% incidence of CVA within 5 years. So CVA is stroke, right? Oh, okay. Yep. All right. So patients who have atrial fluttering and they're not anticoagulated, they have a 25% incidence of a stroke within 5 years. Those patients anticoagulated to therapeutic levels have 4% incidence. Okay. Aspirin is a clearly inferior substitute to warfarin, but it's much more preferable to no anticoagulant or antithrombotic therapy. So aspirin, it's not as effective as warfarin, but it's more preferable to use no anticoagulant if they don't use warfarin for anticoagulation or antithrombotic. What risk calculations score can be used to evaluate stroke in those patients with atrial fibrillation? Okay, the CHADS-2 score. This stands for congestive heart failure, hypertension, age, diabetes, and history of stroke. Because diabetes, of course, is going to affect your blood pressure. Hypertension, age, history of stroke. I'll give 1 point score with 2 points for stroke, totaling 6 possible total points. A score of 6 would give a patient a 19% chance of stroke in the first year with atrial fibrillation. Wait a minute. Wow, so wait, atrial fibrillation, that's a disease? Atrial fibrillation? Yeah, okay, it's irregular. They have the symptoms, and often rapid heartbeat. Chaotic signals. 200 to 175. Atrial fibrillation, it's called AFib, but it's not tachycardia, is it? Is it a kind of tachycardia? Okay, so the type of tachyarrhythmia. Okay. Right. I'm gonna need a lot of context for everything I'm learning, but I think I'll get there eventually. Alright. Just slowly study. Alright. Thanks. So, congestive heart failure, I guess that's if you have the condition or not. That affects your chances of having a stroke. Wait, in those patients, so if you have atrial fibrillation, I'm guessing that's the side effect of congestive heart failure, hypertension, your age, diabetes, and history of stroke. Or your history of stroke has to do with all those conditions, and atrial fibrillation is a side effect. I'll give 1 point, okay, and So all those conditions, they give you the side effects, the symptom of atrial fibrillation. All these factors, therefore, give you a higher chance of having a stroke. What is the recommendation for patients with sustained atrial fibrillation and a CHA2 score of 3? Okay, sustained. So consistent atrial fibrillation. The recommended treatment would be dual antiplatelet therapy with aspirin. Actually, hold up. Alright, I'm gonna review types of strokes. So there's different types of strokes. So thrombotic, it develops and it blocks inside the brain. Embolic, you develop elsewhere and then travels up to the brain. Hemorrhagic, it's having a stroke through bleeding. Oh, okay. I think. Oh, there's two types of hemorrhagic stroke too. When the artery bursts, okay. You can have a stroke by bleeding. Bleeding in the area between the brain and the thin tissue, like subarachnoid. Okay. But why is that different from intracerebral? Oh, it's an artery in the brain, and it's okay. Refers to bleeding in the area between the brain and the thin tissue, subarachnoid. So doesn't intracerebral lead to subarachnoid hemorrhage then? So that's a subarachnoid. Yeah. So intracerebral. Oh, okay. So you have a stroke because it's happening in your brain. Okay. Oh, I get it. I get it. I get it. I get it. Okay. You can have a stroke by bleeding, and you can have a stroke by something blocking the blood vessels in your brain. Okay, that makes sense. All right. Okay. What's the recommendation for patients with sustained atrial fibrillation on a chat with a CHAT score of 3? So the CHAT score, it tells you the chances of developing a stroke. So if you have a 3.2 chance of having a stroke, you recommended dual antiplatelet therapy, which is more intense than platelet inhibition. Oh, which is more intense than single antiplatelet. It's resulting in incremental reduction of risk of thrombotic events after intervention, but it's been associated with increased risk of major bleeding. So PCI is a non-surgical. They use catheter. You place a stent to open up the blood vessel in the heart that's been narrowed by plaque buildup. Oh, I see. Wait, what? Wait, dual antiplatelet therapy. Dual antiplatelet therapy. That doesn't sound. Wait. After doing this, okay. So dual antiplatelet, intense platelet inhibition. Wait, blood platelets? I forgot what they do. Blood platelet. They're thrombocytes. Oh, they stop bleeding. Oh, they stop the bleeding. Okay. Okay. What's the recommendation for patients do with aspirin? And aspirin. Where am I? Where do I find aspirin? Okay, so aspirin is an anticoagulant. Okay, keep getting lost. Okay, I'm so bored. So you want that therapy with aspirin, even though it's associated with increased risk of major bleeding. So obviously you don't use these medicine when you're bleeding, because you want coagulation to stop bleeding. And clopidogrel, guessing that's another anticoagulant or a factor X inhibitor, like dabigatran, rivaroxaban, or edoxaban. They all end with ban and tran. Okay. So what's factor X inhibitor? So it's another anticoagulant, obviously. Okay. What is the key feature of this kind of AV block, atrioventricular block? Let's see how I'm supposed to pronounce that.
Wenky box bundle.
Winky bug. Winky bug. Okay. A progressive prolongation until no longer. They already asked this, right? Through the ventricle until the atrial impulse is no longer conducted through the ventricle, resulting in a dropped QRS. Almost always transient atropine and transcutaneous transvenous pacing is required for instances of symptoms or cardiac stability. Transient. So temporary atropine. What is that again? It's a progressive prolongation of the PR interval. Atrial impulse. So it's a prolongation of the PR interval until. Oh my god, I'm so bored. Resulting in drop QRS. Okay, prolongation PR interval. Almost always transient, like short. Atropine and transcutaneous transvenous pacing is required for the rare instances of symptoms or cardiac stability. Wait, Mobits. What causes it? Malfunctioning AV nodes tend to progressively fatigue until they fail to conduct an impulse. Alright, Denzo.